The next presentation is Parkinson's Disease Best Practices for Person-Centered Care. And we have two really good speakers here today that I think that you'll find very interesting. The first is Dr. Danette Taylor. She is a movement disorder specialist and is board certified in neurology and psychiatry. She received her degree from Michigan State University College of Osteopathic Medicine and has been in practice for more than 20 years. She's very well known in the field of movement disorders. She's service chief for neurology at Henry Ford West Bloomfield Hospital and also sees patients there and at Troy and the Novi location. Brian Cooper is well known to many of you. He's been very involved in the Parkinson's Foundation for many years. He's an occupational therapist with residential home health and also teaches Parkinson's Disease self-efficacy program. He serves on the Professional Advisory Board of the Michigan Parkinson's Foundation, has served on the Symposium Committee, and both of these speakers have been very instrumental in developing today's curriculum, and I'd like to welcome them and thank them for coming, and I'm sure that you'll enjoy their presentation.
Thanks, Paul. Thank you, Paul. Thank you to everybody that came out on this beautiful day. I mean, the sun is finally out, and it's hard to be indoors in this dark room. I get that, but we appreciate you being here. I think, you know, after that overview, and you were able to see me fly up here onto the stage with my wings, right? That Betty did a terrific job giving us a great idea of what the personal part of what we do as healthcare providers are. I think what I'm going to do is give you a very broad overview of the more scientific nature of things, and then I think you'll see that the lectures that follow really are going to fill in all of the gaps from my broad overview. So as you know, if I seem to be a little bit superficial, it's because there's another talk that's coming later today that's really going to hit some of the nitty-gritty part of maybe what you really want to know. And so this truly is an overview of Parkinson's disease and how do we best, you know, really what are the things that we have to focus on and look at. So what is Parkinson's disease to begin with? I mean, we hear of that and we think, oh, Parkinson's disease. Well, I know what Parkinson's disease, well, what is it really? Well, it's a degenerative brain disease at the very basic. So what does that mean? Well, it is a progressive disorder, and patients that have Parkinson's disease aren't static. Their disease changes with time, and one of the important things to keep in mind regarding that is that the way they adjust to their medications, the way they respond to the medication changes with time, the way they respond to physical therapy, the way they respond to other ministrations is going to change over time. And so this is not a static disorder like hypertension where we're going to give you a pill every day and we're not really going to see what's happening. Parkinson's disease changes and evolves, and we have to keep that in mind. Again, it is progressive. It's caused by a lack of dopamine in our brain. So dopamine is a very potent neurotransmitter within our brain. It does a whole lot of things. It is the quintessential feel-good neurotransmitter in our brain if we snort cocaine. It is the dopamine receptors that are really fired up and engaged. And when we're happy and excited and seeking pleasure, it's those dopamine receptors that are really engaged. And so when patients with Parkinson's disease look a little bit flat, it may not be just because of that facial masking that they have. It may be because of that whole imbalance of the dopamine system. And what I tell my residents and students and every patient that comes in and says, well, you know, my neighbor is on the brand new medication that was just identified, and I think I need to be on that brand new medication. Every patient with Parkinson's disease is different. And that's really going to be a flavor of what I talk about on a regular basis throughout this lecture. And it's going to look different in every patient that has it. Keep that in mind. So what is dopamine? Why do we care about dopamine? Again, it is a very potent neurotransmitter within our brain. It doesn't just impact mobility, but it does impact our emotions. And when we don't have enough dopamine, we don't do well. We may not move well, we may have tremor, we may have stiffness, rigidity. If we have too much dopamine, on the other hand, sometimes that can cause other issues. And how many people here know what one of the prime examples of people that have too much dopamine in their brain experience? Schizophrenia, exactly. And so, as you can see, there's a very fine balance between not enough dopamine, too much dopamine, and what we're going to do about that. So, pathophysiology, we always have to have a pathophysiology slide because, this is a scientific basis. So we want to see what we're looking at, and I don't think I actually have a pointer. This is just kind of a forward and backwards. But I think on the top you can see the very dark stripes on the cell, on the part of the brain. And that dark stripe is the substantia nigra. And those substantia nigra cells are what create dopamine in our brain. And when we don't have enough dopamine in our brain, then we develop symptoms that look like Parkinson's disease. Now, the downside is that those cells begin to deteriorate far earlier than we develop clinical symptoms. And in some cases, that's 7, 9, 12 years before we actually see the physical manifestations or characteristic symptoms of Parkinson's disease, that stooped posture, the shaking hand, the slowed walk. If we could identify 10 years ago that maybe that person was going to develop those symptoms, maybe we'd be able to do something about that, but we're really behind the 8 ball by the time our patients come to us. So, and in addition to those loss of substantia nigra cells, we see the development of Lewy bodies, the abnormal alpha-synuclein aggregation within the cells themselves. So what is Parkinson's disease not? So we know what Parkinson's disease is. It's not yet curable. That certainly is what our holy grail, right? Looking for a cure for Parkinson's disease, trying to figure that out. But it's not fatal. And I think that that's something that we always have to keep in mind as we are interacting with our patients. This is not a fatal disease. This is something that people are going to live with for a long, long time. And I have patients in my practice that have had Parkinson's disease for 16 years, for 18 years, for 24 years. In one very notable case, a woman who was diagnosed 31 years ago, and she is still living with her husband. She has some assistance, but she could walk from this stage outside, grab a cup of coffee and a pastry, and come back in with her walker. So patients with Parkinson's disease don't have a straight line illness, boom, they're done. We have to keep that in mind as we are caring for them. So how many people actually have Parkinson's disease? And this number actually, I think, is a little bit of a surprise that in the US, it's about 1 million people, which is, not a huge number, but it's certainly substantial. But it is more than those individuals who have multiple sclerosis, muscular dystrophy, and ALS combined. And so when we look at that, there are drug after drug after drug coming out to treat multiple sclerosis, and there are advertisements regarding how to treat MS, and everybody and their brother knows what ALS or Lou Gehrig's disease is, and Jerry Lewis has a giant telethon raising billions of dollars for muscular dystrophy. But what the heck happened with Parkinson's disease? Many more people actually, in fact, have Parkinson's disease in our country. About 60,000 are diagnosed every year, but maybe that's not even everybody. A lot of times as people age and they slow down a little bit and they get a little bit quieter, we kind of ignore some symptoms. Oh, well, Dad's just getting older. Oh, he had cardiac surgery. Of course, his voice is going to be quieter. He had a tube in his throat, and he's just kind of recovering from everything. Oh, you know, when you're 93, you tend to slow down. Well, maybe it's not just all of those things, and we have to keep in mind that not everybody with Parkinson's disease has tremor. We're going to talk about that in just a moment. But here's another, I think, very startling number. Mean age of diagnosis is 58 to 61. And we always think of Parkinson's disease as a disease of the elderly, right? How many people out there think 58 is elderly? Yeah, I'm not seeing a whole lot of hands. I don't either. So 58 is still relatively young, quite young in some cases. And so Parkinson's disease isn't just a disease of old people. So cost of Parkinson's disease. Here's another very sobering number. Up to $25 billion per year, that's direct and indirect costs. What does that mean? Direct costs, cost of medication, cost of doctor visits, cost of hospitalizations, cost of durable medical equipment. What are indirect costs? The time that somebody takes off of work to take somebody to that doctor's visit, the time that somebody has to take off of work to care for somebody, the amount of money that somebody is paying to purchase special equipment that's not covered by insurance, $478 a week for a gait belt, et cetera, et cetera. So it's not an inexpensive diagnosis, unfortunately. So what are the risk factors? Who gets Parkinson's disease? I'm going to go through this very rapidly because it's not the focus of our topic. But bottom line, if you're a little bit older, maybe. If you're male more than female, you might be more at risk. If you have a family history to some extent, and we'll talk very briefly about genetics. So life experience, maybe trauma. Let's think about Muhammad Ali and repeated head traumas. Will emotional stress or personality? Probably not lead to any problems. Environmental, there's a whole list of potential environmental risks, but they're not an absolute. We know that because we're not seeing giant cohorts of individuals that are on a single farm that have Parkinson's disease. We're not seeing big cohorts of individuals in a specific neighborhood that drank the same water from the same well that have Parkinson's disease. So we know that those are potential issues, but not absolutes, and ultimately, we don't know why somebody gets Parkinson's disease. It is my personal belief that that's going to be the key to a cure. If we can figure out why somebody gets Parkinson's disease, we'll be able to figure out how to stop it and make a big difference. So we need to keep figuring out why do people get this, and we haven't done that yet. So ultimately, it's probably a combination of both. There's probably something within our genetic makeup that makes us more susceptible to some outside influence, which then leads to Parkinson's disease. But we don't know what those nebulous factors are yet. And as I said previously, the ability to identify these preclinical cases, 7, 10, 12 years as those dopaminergic producing neurons begin to taper away within our brain, that's the time that we really want to identify who's going to develop this. But bottom line, who ends up in an assisted living facility, and why do they end up there, and what can we do to help care for those individuals once they get there? So picture on the left side, what is that? Somebody that's taking a header down the stairs, right? And when somebody starts falling repeatedly and they cannot get themselves up, or a family member is no longer able to get that individual up safely, that's a big factor that leads to placement within an assisted living facility. The patient on the right is obviously in some anguish, but that's meant to identify some issues with behavioral outbursts, hallucinations, cognitive decline, which also then leads to either assisted living facility or long-term care facility. So let's talk again very briefly about the main symptoms that we see with Parkinson's disease. So the cardinal features, what does somebody have to have when they come into the clinic that we can say definitively, you've got Parkinson's disease? So we're looking for tremor, but not everybody has tremor, darn it. So 2/3 of patients with Parkinson's disease are gonna have some component of tremor, but we don't always hang our hat on that because there's 1/3 that don't. Bradykinesia or akinesia, what does that mean? That's that generalized slowness, maybe a slowness of response, slowness of movement, slowness of walking. Probably one of the most egregious examples of insensitivity to the slowness that patients with Parkinson's disease has was a medical assistant in my facility who told a patient with Parkinson's disease coming in from the waiting room, "Come on, hurry up." Patients with Parkinson's disease are slow. So rigidity, that's not something that you're gonna see on an exam, or as you're just observing something. That is something that we find on examination. We're looking for a specific type of rigidity that patients with Parkinson's disease have. Postural instability, patients are gonna end up in an assisted living facility. If we see postural instability very early on in the disease process, we have to start worrying that maybe it's not run-of-the-mill Parkinson's disease, maybe it's something else. And again, we can touch very briefly upon that in just a little bit. So other symptoms that we're gonna see in addition to that tremor, slowness, rigidity, the diminished arm swing while walking. And patients very often say, "Oh, I saw a neurologist, he had me walk up and down the hallway and told me I had Parkinson's disease." There is a very characteristic change in our ambulation as patients are walking. And when we have Parkinson's disease, and very often it is a decreased arm swing. Is Parkinson's disease the only thing that leads to a diminished arm swing while people walk? No, absolutely not. And that's where some of the other nuances of examination really come into play. So micrographia, the picture here is an example, a very nice example of micrographia. There was a patient that we had writing a specific word, and she said, "Oh, I can do better than that, I can do," and the more she tried, the smaller her handwriting it got. Very characteristic micrographia associated with Parkinson's disease. So hypophonia, that's that quiet voice the patient with Parkinson's disease very often get. So facial masking, or that sense of just lack of responsiveness, show shuffling gait, stoop posture, we saw pictures of that, but those are all very commonly seen with patients with Parkinson's disease. So typical progression or clinical course, and typical is in scare quotes here because patients don't read the textbooks, right? They don't always follow the picture. And again, we've got that preclinical phase where patients might have issues with some constipation or loss of sense of smell or something, but then they're finally identified or diagnosed. And then they tend to be fairly stable for a period of time. These numbers are taken from initial observations by Drs. Hone and Yar. If anybody has heard of the Hone and Yar scale that we very frequently use to quote unquote rank or rate Parkinson's disease. And they kind of put these observations together that, you know, if somebody was initially diagnosed with Parkinson's disease, you know, they're gonna kind of be fairly stable for up to 3 years or so, and then they're going to be on medication, and then they're gonna start developing some issues or complications associated with that dosing of that medication. That's gonna last for about up to 8 years or so, and then patients are gonna develop quote unquote resistant symptoms. And we can, I think Dr. Wyant, who's gonna talk about medication, will better identify, what is quote unquote a resistant symptom, which then may last for about 15 years or so, and then cognitive decline, which begins. Again, we know that not everybody follows the same pathway, and I have had patients that have had the diagnosis, onset of treatment, honeymoon phase, which has lasted for well into 7 or 8 years, which is very fortunate and nice. And then their rate of decline is certainly much, much different. So this is typical, but we can't hang our hats on this. So new thoughts. Well, we know there's widespread pathology. It's not just necessarily in the brain, and we're gonna look at that. Non-motor symptoms are a huge component of individuals with Parkinson's disease, and I have a specific slide that we're going to talk about. What are those non-motor symptoms? How does that impact what somebody is experiencing? What about prodromal symptoms in that -2 to -10 years? Maybe if we start looking at things like patients that say they can't smell anything, it's not just the Michigan nose, they don't just have environmental allergy, it's not just allergic rhinitis. Maybe that loss of sense of smell is something that we need to really specifically look at and focus on. REM sleep behavior disturbance. So are we familiar with that? Those are patients that talk in their sleep, try to punch a bed partner in their sleep, maybe in some very extreme cases actually get out of bed and start trying to do something else in their sleep, like dive down a flight of stairs or something along those lines. So we know that REM sleep behavior disturbance and Parkinson's disease very frequently go hand in hand. Constipation, very commonly identified in patients with Parkinson's disease, maybe many years even before the motor symptoms of Parkinson's disease are recognized or identified. Cardiac symptoms, really that is more blood pressure fluctuations, autonomic instability, hypotension in patients with Parkinson's disease. We don't yet have a blood test or specific x-ray that can tell us definitively that somebody has Parkinson's disease. Even today, June 14th, 2019, it is based on a clinical constellation of symptoms that we identify. Now, okay, we have a DAT scan. Why would we get a DAT scan? Well, patients, again, don't always read the books. They don't present as a specific constellation of typical symptoms that we're looking for. And so if somebody has some confounding factors, a nuclear medicine study called a DAT scan can sometimes help us identify, is this a Parkinsonism or might something else be going on? Now, you'll notice there that my comment was, is this a Parkinsonism? Because DAT scans aren't specific to tell us it's Parkinson's disease per se. And Parkinsonisms can include multiple system atrophy or progressive supranuclear palsy or even normal pressure hydrocephalus or Lewy body dementia. And so a DAT scan can't tell us the difference between idiopathic Parkinson's disease versus one of those other symptoms. So, but it can certainly tell us the difference if somebody has kind of an unusual action tremor versus a Parkinson's disease. So biomarker identification, this is kind of interesting. It's been in and out of the news for the past many years. And that is, we do know that some changes that are seen within the brain can actually be identified within the nerve cells of our intestinal tract, within the myenteric plexus of our gut, in patients with Parkinson's disease, but not one of those Parkinsonisms. So that's kind of exciting information. Now, the downside is that those changes within the gut aren't there for a long, long period of time. So at what point would we start looking for those? And it is, but it's certainly something that we need to explore a little bit further. So genetic factors, many, many different sites for gene disorders in Parkinson's disease have been identified or recognized, but they still are a very, very small percentage of individuals with Parkinson's disease. And so one question that comes up repeatedly, well, I have Parkinson's disease, what should I tell my children? What's going to happen to my grandchildren? What's happening here? And at this point, we can safely say, well, the majority of cases of Parkinson's disease are idiopathic, meaning we don't have a cause. They're probably not familial. If there is a familial component, we're still going to treat it the same way. So, Parkinson's disease considerations. Now, I've got this bunch of cookies here because in healthcare, we like things. If it's a complicated field that we have gone into, there's a lot of different things that we have to know, and we try to make things as easy as possible, sometimes to the point of having a cookie cutter approach to how we are going to address each of our patients. Unfortunately, it doesn't really work with patients with Parkinson's disease. So So what is the best treatment for patients with Parkinson's disease? Paul, should I call on you? What's the best treatment for people with Parkinson's disease? The best treatment for Parkinson's disease is the treatment that works for that specific patient. So and so what's our approach? Well, we have to look at what are their short-term goals, what are their long-term goals, what are potential side effects that we're going to be thinking about. What are they able to do today? What do they want to be able to do down the road? How long have they had Parkinson's disease? We talked about that evolution. This is a changing disorder, and treatment needs to change, sometimes every 6 months, sometimes every couple of years, sometimes more rapidly, but it really depends on the individual. And so our treatment plans have to evolve as Parkinson's disease evolves. So maybe we need to increase a dose of medication, maybe we need to decrease a dose because of issues with side effects, but it's not just the Parkinson's disease that we have to think about. We have to think about how old is that patient? Is our patient 58 or are they 88? What associated symptoms do they have? Do they have congestive heart failure? Do they have asthma? Do they have gastrointestinal reflux? Do they have something else? So do they have diabetes? What other factors are ongoing that we have to think about as we're trying to treat our patient with Parkinson's disease? What's going to happen? I mean, I always tell patients that I feel like a pill pusher when we have people with Parkinson's disease, because very often we're adding more and more layering treatments on treatments in an effort to control all of their symptoms. But if I'm prescribing 3 or 4 different medications, all of which have a copay of anywhere from $20 to $50, how many other medications are these patients on? And what decisions are they making regarding which medications they're actually going to treat because of the cost? So nobody wants to hear about cost of medication. Nobody wants to hear about cost of treatment. But it is a discussion I have with patients on a daily basis. This medication should not cost too much out of pocket. But if it does, we'll try to figure something out. So what are our treatments? Again, Dr. Wyant is going to go through these far more rapidly, but it's good to have just a quick introduction. You probably are aware already. Levodopa, that's our gold standard, comes in many different forms. So Sinemet and generic carbidopa-levodopa, and levodopa intestinal gel now, and Parcopa, which is the orally dissolving version, and Rytari, which is the longer acting version of carbidopa-levodopa. There are multiple different dopamine agonists on the market, pramipexole or brand name Mirapex, ropinirole or brand name Requip, rotigotine or brand name Nupro, that's the patch one, apomorphine with the injectable rescue medication or brand name Apoquin, monoamine oxidase inhibitors, which are many different versions, rasagiline or Azilect, selegiline or Eldepril, sulfinamide, or that's the new Zonegran, or not Zonegran, zonisamide. So anticholinergic agents, Artane or trihexyphenidyl, benstropine or Cogentin, amantadine, very often used to treat Parkinson's disease. Again, intestinal levodopa gel, or deep brain stimulation is an option. And if a patient has deep brain stimulation, how does that impact your ability to care for the patient? How many people believe that if you have deep brain stimulation, you don't have to be on pills anymore? It eliminates your need for medication. Good, nobody, because it doesn't. There's a combination approach, and the vast majority of people that have had deep brain stimulation still need to be on oral medications on a regular basis. So, again, Dr. Wyant is going to go through this more in depth, but just very briefly, different sites of action of medications. So levodopa gets into our bloodstream and then goes across our blood-brain barrier and then is turned into dopamine. We can't give patients dopamine in oral form because it'll never get up into their brain, and it's not going to be effective for them. So we have to give them the building block, which is levodopa. All of the other medications work on either the dopamine receptors or in some way interfere with how levodopa is broken down or how dopamine is broken down within our brain to help that medication last a little bit longer. So why do we treat patients with Parkinson's disease? Well, because we want to help them improve functionally, right? We want to potentially decrease the accumulation of motor disability. What does that mean? Well, if somebody's not active or immobile for a long, long period of time, what happens to them? They get weak, and they become less mobile and less functional, right? So by keeping somebody mobile and active, that helps improve long-term functionality. Downside, current treatments don't offer neuroprotection. What the heck does that mean? That means we can't stop that ongoing progression of Parkinson's disease as time goes on. So, and at the best, patients with good response to treatment from Parkinson's disease can go from being very immobilized to being very functional, looking very normal. And it's always a terrific response when somebody comes in and says, you know, on my current program of medication, I was at a meeting, I was at a church group, I went to lunch with some friends, and they all told me that they didn't believe I had Parkinson's disease because I was doing so very well. That's not a pipe dream. That is something that we can achieve with medications. So, but let's talk now about problems that patients with Parkinson's disease have. What the heck's an off episode? What does that even mean? How many have heard, you know, of patients that are on or off episodes with Parkinson's disease? So if this is new terminology, then that's something that we should go through. So an off episode, when patients have Parkinson's disease, they suddenly feel as though their medicines just are no longer working. They've just stopped. And they've gone from being very functional and mobile to being stuck. And as disease progresses, those off episodes can occur unexpectedly. They can occur when a medication wears off because the end of the dosing time frame has occurred, or the dose of medication that somebody has taken may just never take effect. And so an off episode is something that is a very real problem for patients with Parkinson's disease and can impact their ability to take care of themselves at home, to create a meal for family members or themselves, to participate in physical therapy or pretty much anything. So long-term challenges is what happens when we give somebody levodopa. And as we're looking at this, so in early Parkinson's disease, our brain's response actually lasts for a fairly long period of time. We give somebody a single dose of medication, and the levodopa gets up into their brain, gets turned into dopamine, and that dopamine effect lasts for, in some cases, 6, 7, even 8 hours. How many people out here remember pharmacology way back when and know what the half-life of levodopa is within our bloodstream? Everybody, okay. This is always, I think, a surprising bit of information, even to patients. The half-life of levodopa within our bloodstream is 1.5 hours to 2 hours for most individuals. That's not very much time at all. And remember, we talked about the fact that our brains evolve and change with Parkinson's disease? Well, what happens as our brains evolve and change is that, you know, as we have, you know, moderate Parkinson's disease, we've had it for a period of time, then our brain's response is no longer 6 or 8 hours, it's closer to maybe 3 or 4 hours. And then the effect of the medication is no longer there. And when we have advanced Parkinson's disease, sometimes what's happening within our brain begins to mimic what's happening within our bloodstream. And the effect of that medication lasts for a very, very short period of time, in some cases an hour, maybe an hour and a half to 2 hours, again, mimicking what is happening within our bloodstream. So what does that mean for you as caregivers in a long-term care facility? That means that one-size-fits-all, we dose medications at these specific times may not work at all for people with Parkinson's disease because of this change within their brain and their change that they're experiencing to medications as their disease progresses. And so if somebody comes in with what looks like a fairly complicated program of medication, they're on a dose of Sinemet every 2.5 to 3 hours, and you're like, well, we can give a dose every 4 hours. It'll work out just as well. Probably not. For this specific reason, those changes within our brain, the way those dopamine receptors respond to the dopamine within our brain, and how much those have changed over time. So, how do we manage an off episode? What does it look like? What symptoms does somebody have? Well, an off episode may be different for every patient with Parkinson's disease. If somebody's symptoms remain tremor predominant, their off episode may be a significant amount of tremor that has recurred, and that tremor may be very difficult for them to function, do something to function with. And maybe that's somebody that at their best is relatively independent, but when that tremor comes back, suddenly they need a whole lot more help. Well, maybe we need to start looking at dosing of medication or what specifically happened there. Again, when do those off episodes occur? And that's where patient feedback becomes very important to say, okay, how are you feeling right now? Is your medication working? Patients are able to recognize that. They can tell that. I know when my medication is on and when I'm not feeling well based on the dosing strategy of the medication, and patients can tell you how their medication is working. And if you are, if you need to shower somebody, if you need to take physical therapy, occupational therapy, speech therapy, to confirm that somebody is having a good response to their medication at that time when you're trying to administer those therapies to them, really is only going to make that effort that much more productive, and the patient is going to do that much better. When we try to get somebody to stand up and have them walk around, but they're in the middle of an off episode, we're going to say, well, okay, this patient is not in a position to participate with therapy. That's going to change our long-term outcome, potentially in a detrimental manner to that patient, because we may eliminate some of the care that we might otherwise have offered because we did the assessment at a point when they weren't at their best on time. And so we always have to keep that in mind. So, and again, why do off episodes occur? Well, we know that off episodes occur for a myriad of reasons, but the most common are end of dose wearing off. So somebody has a defined amount of time where their medication is going to work, and after that period of time, it's not going to work anymore. And so if somebody has recognized off episodes every 4 hours and dosing of medication is occurring every 6 hours, they're going to have a big chunk of time during the day that they're just not doing very well. But we have to recognize that. Sometimes medication just isn't absorbed quite as well, and we may need to give a bit of a rescue dose of medication. And sometimes it's early morning, somebody that gets up first thing in the morning, the dose of medicine that they've had the night before is no longer there. As we've seen, medications for Parkinson's disease are not in our bloodstream, they're not in our brain 24/7. And so a dose of medicine that is given yesterday has nothing to do with how well somebody's going to do today. And we need to keep that in mind. What about freezing of gait? Does everybody know what freezing of gait is? So I have to ask that question because we have patients that come in and we ask a questionnaire, do you experience any freezing? Well, only when it's cold out. Okay, so there is still some misconception of what specifically is freezing of gait. And so just so we're all on the same page, freezing of gait is somebody with Parkinson's disease wants to take a step forward and they can't. Their leg won't move for whatever reason. Now, unfortunately, freezing gait is hard to treat medicinally, but many patients will respond to different cueing techniques, if freezing occurs. And so sometimes if you encourage them to take a big step, they can take a big marching step and get going again, sometimes having them take a step to the side, take a step backwards. Walking out of the automatic component and making patients think about it in a different manner can help with freezing of gait. If somebody has freezing of gait, not just when they're starting out, but when they are going through a doorway, which is very commonly seen with Parkinson's disease, having them count their steps as they go through the doorway is a nifty trick to help them continue through. Having patients listen to music as they're walking can help dramatically reduce incidences of freezing of gait. So all things to think about. What about dyskinesias? Is everybody aware of dyskinesias? So at the basis, abnormal kinesia movement. How many have seen Michael J. Fox on a press release? And he's moving, those are dyskinesias. Those are very commonly associated with dosing of levodopa, very often as a peak dose effect of the medication. Sometimes as the medication wears off, patients develop dyskinesias. Dyskinesias aren't always quite so florid or prominent as we see sometimes on television with Michael J. Fox. Sometimes they are more subtle, maybe just some mouth movements, or maybe just some head nodding, or maybe as somebody's walking, their arm is way out behind them. Those are all very common examples of dyskinesias that we can see, but we want to keep an eye on those to make sure that those aren't going to interfere with our ability to administer care to our patients. So, non-motor symptoms of Parkinson's disease. This is a complicated slide, and it is meant to be a complicated slide because non-motor symptoms of Parkinson's disease are a complicated condition for patients. And all of these factors that we see, depression and anxiety, specific mood disorder, cognitive decline, sleep issues, drop in blood pressure, gastrointestinal and genitourinary issues, and motor symptoms, all actually are combined and interfere and interact with each other. So what does that mean? Well, if somebody with Parkinson's disease doesn't sleep well, they're not going to think as clearly, they are not going to move as well, their mood may not be as well controlled. If somebody with Parkinson's disease has frequent urination, then they're not going to sleep as well because they may be up frequently through the night to use the bathroom, and then that may be difficult for them to get back to sleep, so the sleep is interrupted. If they have frequent urination, then maybe they're not going to drink as much fluid. And so the risk of hypotension, especially orthostatic hypotension, suddenly goes through the roof. And if they're not drinking enough fluid, then issues with constipation become much, much higher. What happens when patients with Parkinson's disease are constipated? Their medications aren't absorbed as well, specifically levodopa. Levodopa has to move from the stomach into the intestinal tract to actually be absorbed. If anything slows that down, then absorption of medication is going to be declined, and response to medication is going to be much, much worse. And so these are all things that we have to think about, and they all interact together. So again, and We have to think about issues with hallucinations. Sleep disturbances are so common in patients with Parkinson's disease that some individuals think that maybe Parkinson's disease is in fact a primary sleep disturbance. More than 90% of patients with Parkinson's disease have problems with sleep issues. And how is that going to manifest in an extended care facility? Well, patients may be sleepy through the day. They may not want to sleep at night. They may wander the halls at night. Those are all things that we have to keep in mind and take care of. Again, autonomic dysfunction leading to issues with urinary urgency and frequency, orthostatic hypotension, constipation, a drippy nose. Patients with Parkinson's disease very often develop issues with what we call vasomotor rhinitis, and as they're attempting to eat, they develop a lot of mucus coming from their nose, and that's distressing for them and distracting for them as they are trying to eat their meal. So patients with Parkinson's disease can have some uncontrolled issues with sweating. Sexual dysfunction, including erectile dysfunction, very common in patients with Parkinson's disease. So, benefits of physical activity. As caregivers, we want to emphasize physical activity in patients with Parkinson's disease. There is specific physical therapy for people with Parkinson's disease, LSVT big, LSVT power, and we encourage patients to emphasize big amplitude movements because that really does make a difference. We encourage patients with Parkinson's disease to move every day. If you have Parkinson's disease, make exercise a priority, take it as seriously as you take your medications. We try to emphasize that to patients, and what kind of a difference can that make? Okay, these are not ham steaks that I took at a picture of Kroger. Okay, on this top picture here, that's the thigh muscles of a 40-year-old triathlete, okay? The picture right below this are the thigh muscles for a triathlete who's 70, okay? So we don't just lose muscle just because we age. This picture on the top left, top right rather, is a sedentary 70-year-old. Again, 70-year-old triathlete, 70-year-old sedentary individual. What a difference that makes. When we lose muscle mass, we get weak, we can lose endurance. We don't have pills to make people strong. We don't have pills to give people better endurance. What does that? Regular exercise, regular movement and mobility. And when we focus on all of these different factors, our patients are happy campers. They're happy cookies. So, but it is a unique and individual approach to every patient that we have to keep in mind. So, Parkinsonism, very, very briefly, PSP or progressive supranuclear palsy, multiple system atrophy, corticobasal ganglionic degeneration, Lewy body dementia. I bring those up because very often patients that have a Parkinsonism will be treated as if they have idiopathic or regular run-of-the-mill Parkinson's disease, and then we wonder why our efforts aren't working. It's because although they have a similar name, they're very different diseases, and patients with these conditions are not going to do as well. They're going to progress much more rapidly. They're not going to respond to medications as well. And so we always have to think about one of these conditions when our patients with Parkinson's disease don't seem to be responding the way we would hope they would or expect them to. So, bottom line, what's the best treatment for Parkinson's disease? And again, it really depends on the patient. So, conclusion, really there is no one-size-fits-all for people with Parkinson's disease. Our patients we can keep them doing very, very well for a long, long time. And that is, I hope that you would keep that in mind, that no matter the fact that we have to think about this, and there is not a one-size-fits-all, but we can help people for a long, long time when they have this condition. And last but not least, not all the symptoms that patients have are necessarily related to their Parkinson's disease, okay? We see that time and again. Somebody comes in and they've got, you know, a big lesion on their scalp. Well, I thought that was from my Parkinson's disease. And no, honey, let's get that checked out. Oh, look, it's a basal cell carcinoma. Aren't we glad that we had that lopped off? So not all symptoms are related to Parkinson's disease. When somebody has a symptom, let's delve in, dig a little bit deeper, and then sort that out. So where do we go from here? Well, Brian's going to talk a lot more about motion and activity, but our greatest weakness lies in giving up, not just for us, but for our patients. So let's give them a sense of hope. So the most certain way to succeed is to try just one more time. And I think very fitting that Henry Ford said, whether you think you can or you think you can't, you're right. So thank you for your time and attention. And I might be able to take just a very few questions right now, but I know there's a lot of time for questions at the very end. So, okay.
Anybody in the back want to come sit down? There's a few chairs up here if you're getting tired of standing. It'd be all right. We're good? Okay. My job is to go ahead. Well, unfortunately, we're a little short on time, and that didn't help anything, I suppose. So I'll save all my best material for later. And then, Dr. Taylor, you did a great job of simulating dyskinesia, because all therapists probably got a little bit worried when she was doing it. I'm like, oh, I thought I was going to have to catch her. But it's Fall-Free Friday. There's no occurrences on Fridays. That's my material right there. So we're going to talk about managing freezing. And again, I'm trying to think about this in more of a clinical setting, nursing homes, facilities, hospitals. What can we do to help people with freezing? The first, and I kind of kept them to the point, and it was just a little bit of topics or bullet points to kind of help us as clinicians or people in facilities helping people mobilize with Parkinson's. So the first things first, if they're using a walker, and I'll kind of demonstrate, if they're on their toes and they're stuck in freezing position, the best thing that we can do at that point for them is make them feel safe, all right? So a lot of times it's my hands that say more than my mouth does. And I find that's kind of reassuring for people that have Parkinson's, especially if there's cognitive challenges too, because sometimes I'll start getting panicked and I'll start talking about different things and it'll cause more confusion. The one thing I can do is, if I have a gait belt, is just kind of help them get the weight back onto their heels, okay? So I always say we want to reset them in what they're doing. So off the toes, because they also get into that kind of, they're really stuck, the walker's going forward, and they're kind of falling forward. So my first thing is just kind of help that gait belt or my hand on their hip and get the weight back flat on the foot, okay? Or I'll say, bring your weight back to your heels. But again, most often it's my hand that's doing the talking. So just reassuring them, that's one way to start. From there, like Dr. Taylor mentioned, we want to find what external cue works for them, all right? Is it to say that we're going to go ahead and kind of march in place to get the muscles going a little bit? If somebody's freezing, sometimes I like targeting a lot. Depending on the kind of walker, if it's a rolling walker, I can kind of put my foot in the space and say, step to my foot, no problem. If you think about the concept of the U-step walker, it's set up with external cues, correct? Well, it can be. If you have a laser, you can use the laser. But even on some of the newer ones, I noticed that there is like a glow-in-the-dark tape on the back part too. So I try and have them kind of step to that, all right? Use that as a target to get their foot up to that mark. All right, so that's one thing. The U-step also, you can get it with a metronome too, to kind of get that sound to help develop the movements or initiate the movements. So those are the first kind of steps to manage freezing. Walking into the bedroom, I had a gentleman, and we know that freezing can, it's pretty predictable. We know where it's going to occur. Sometimes it's the transitions when they're kind of going from one surface to another, whether it's a tile floor to a carpet, or just going through the doorway. I had one gentleman, we would walk upstairs, did a fine job, start turning toward the bedroom, and as he approached the bedroom, he'd start kind of anticipating the door frame, okay? So we could have an external cue past that, something on the ground to kind of mark or say step past that. What we ultimately ended up doing for him, and why I say it's a behavioral modification, is because you want to break the cycle of thought. he learned to anticipate it, so every time it was going to be a problem. His behavioral modification is, when we came upstairs, I said, hang a left. So we walked into a room to the left, he had no problem, came back, and then he went into the room without difficulty. So from all of the things that I've looked at with managing freezing, I think it's more of a behavioral modification. And by that I mean recognizing what's causing the problem, and then trying to anticipate the need and break the cycle of thought for them. Okay, so whether it's an external cue, auditory, step big through that, hit your heel, make sure you're gonna hit your heel on this one, and just kind of coach them through that. In a perfect world, we'd make it so that they don't necessarily always have to have somebody providing the external cue. It might be that we have like a little mark on the floor that they're aiming toward, because as much as they don't want to be told how to do things or keep hearing it over and over, sometimes the caregivers get a little bit burned out doing it too. So we can kind of help coach them for success. So counting, marching, weight shifting. I like weight shifting too. I think that kind of helps. So once I get their weight back onto their heels, we'll just kind of rock the hips a little bit to just get them moving out of that freezing cycle, and then we go for it. Again, too, the benefit of the U-step walker is making sure that they're letting go of the brake so it stops, so it provides a stable surface for them to get out of that kind of forward momentum, because that's problematic too. If they're using a rollator, sometimes it can get away from them a little bit too, and that's challenging. Okay. Managing dyskinesia, and forgive me for I think there's a spelling error in one of these right down at the bottom there. I apologize. I think dyskinesia, and Dr. Taylor already brought that up too, I think it's important to recognize when we need to reach out to the physician to kind of talk about what options there are. I did a presentation not too long ago in Grosse Pointe, and there was a gentleman that was really struggling with his dyskinesia, and he had seen his neurologist not too long ago, and he was supposed to go back a few months later, but his dyskinesia really increased. So I strongly encourage him, and I think he would agree, is to, you have to reach out. You can't struggle for 3 months with something that's really affecting the quality of your life. So I said, hey, you know what, if this medication change isn't working for you, you need to reach out to your physician and let them know. Because, I don't think you would want anybody to wait 3 months to say, hey, this was horrible change. I wouldn't anticipate any physician would. So I really think that that's important. As clinicians and professionals, recognizing the cycle of that, because you can kind of, if you've worked with somebody pretty consistently, you can know when these things are going to happen. Like we talked about, maybe like at the dosing, so they're just getting the medication in their system and they start rocking a little bit more. Talking about something like maybe a amantadine to help, or there's other pills too that you can help with the dyskinesia. Those are the strategies that I have. I would try and plan my tasks, whether it's difficulty with eating and things like that, around the dyskinesia, if you can kind of keep a journal. And that's the benefit of having a journal, is you can kind of develop a routine or a rhythm of when things are going to occur. Okay? Balance. As healthcare professionals, I think it's important for us to recognize when there's changes in balance. Okay? Sometimes that can fluctuate a little bit. There can be different variables that contribute to that: medication changes, urinary tract infections, visual changes, vestibular issues. There's a whole bunch of different things to consider with balance. I do think, and again, as a healthcare professional, I like to know how many falls people have had. And again, we have to be kind of intuitive with that too, because they're not necessarily forthcoming with that information. My favorite is when I see bruises on their arms and scabs on their knee, and I ask them, I said, when's the last time you had a fall? And they say, I haven't had any falls. What would make you think that? I'm like, well, the scabs on your knees or the big bumps on your arms. As clinicians too, instead of number of falls, you might say how many near falls, because that makes them sound more of like a hero. They're like, whew, there was a close one, but I was able to catch myself. Of course, they told me to catch themselves on the ground, but we know that still counts as a fall. Reaching out to the physician to initiate therapy. If you've noticed a change or they're having more falls, request therapy be ordered, okay, PTOT. Speech therapy, obviously, if there's other concerns in regard to speech or swallowing difficulties, because we worry about that as well. Have them participate in exercise programs. All right, again, this is more nursing home, assisted living, I guess. I'm trying to present to everybody in a professional setting. We see people in different settings as well. If they're in an assisted living facility, some of the ones that I've been to now, they have some pretty good exercise programs. Some of them even include Otago. I like Otago. It's a pretty simplistic exercise program that's evidence-based to help to reduce the risk of falling. You can find some videos on YouTube. I like to kind of use that as a visual guide for my people to follow. And it's not horribly complicated, and we can teach it in a safe way. The big thing is, we see a lot of people too that might not necessarily be using an assistive device, a walker, cane, U-step, and we kind of see that it's necessary at a certain point, so we have to encourage the transition to that and make sure that we present it in a way that they're going to receive it well. That's important too. So say, hey, I notice your frequency of falling is going up. We need to talk about what we can do to keep you safer. A lot of times when I'm talking about transitioning to a walker, I like to make sure that they understand that it's going to give them the ability to have more confidence with their ambulation so that they can do it more frequently and maintain their strength. I think that's important, as we talked about with the benefit of exercise, is that we want to keep them mobile, all right? So that's important. Preventing falls. I think I can go on all day about preventing falls, but I won't do that to you. When I'm working with somebody, I never take for granted that they're going to be okay moving around. We know that Parkinson's is ever-changing, and what you saw 5 minutes ago might not be what you get 10 minutes from then. Okay, so it's really important to recognize that there's a great benefit to using a gait belt. I don't have to pull in their limbs. It provides them reassurance. Sometimes they don't necessarily like the looks of it, but we reassure them to say, hey, this is just in case. It helps me feel safer helping you, okay? Because we can use that to kind of help let their body know what we needed to do also. Like I said, kind of getting that weight back. Not pulling, not leading, but just kind of gently helping them to get the weight back. Depending on where they're at, I think it's critical to recognize the benefit of having them in the appropriate room or have things set up appropriately for them. Good lighting, proper footwear. I have a lot of people that slide off of beds because of the height of the bed. They don't really have anything to hold on to. They don't have the appropriate footwear. And then keep in mind that a lot of people with Parkinson's, I don't want to overgeneralize, but I would say most, have a tendency to come up on their heels, right? They're kind of leaning backward when they come up into standing, so the feet want to kind of shoot out. So recognizing the benefit of having good footwear to help prevent that. Grab bars, elevated toilet seats, toilet frames, a shower chair. You can use a tub transfer bench, non-skid strips, chair alarms. I'm going to just comment on the grab bars real quick. I think it's important to recognize that somebody that has Parkinson's might benefit from grab bars placed in different places than somebody that doesn't have Parkinson's. And by that I mean simply that it's very hard to, if you have a horizontal bar next to you, it's great for sitting down because you can kind of use that for support. But to push yourself up into standing, it's quite challenging. So if I have a bar out in front, pulling yourself up makes it so much easier to stand. So we talk about proper placement of grab bars. I harp on my wife a lot about that because she's an architect, and I go into some assisted living facilities, and it blows my mind that they never really consult. It doesn't look like they consult OTs because I'm like, this really isn't functional. So I pick at them. She was explaining to me the reasoning for that yesterday, but I said it would be good to maybe kind of see what functional is, because functional is different than what code is, right? Good. Chair alarms. For those that fall frequently, sometimes we have to get the chair alarms involved. Bed alarms in a hospital setting. There is some dementia sometimes in the later stages that we can come across. That could be problematic. So cognition will be impaired. They might be a little bit more impulsive. That can happen. Or the fact of the matter is that in preventing falls, they might be getting up to go to the bathroom, which is a legitimate thing. So when bathroom checks occur, it's important to say, hey, let's go to the bathroom. Because it depends on when you ask somebody, they might say, well, I've already gone to the bathroom or I'm good. Yes and no. I watch that a lot too, and I'm a little bit critical of that because I see bathroom checks and people come in there and they're like, hey, Mr. Smith, are you okay? And they sign the little log. But Mr. Smith really needs to go to the bathroom, just like anybody else might. But I think it's all in how we approach it and kind of encourage them to have assistance in getting there too. So I think, in my opinion, one of the biggest reasons why people fall is because of incontinence, whether they're trying to get up at night. And we know the frequency of urination often increases at night because if they've been sitting all day too, they're getting all the swelling, and then when they lay down at night, all of a sudden it's 3, 4, 5 times a night wanting to get up and go to the bathroom, which can be a problem all in of itself. But you can manage that by trying to elevate a little bit throughout the day. There's different techniques, controlling the fluids after 7 o'clock, 6 o'clock, 7 o'clock, different things like that. I think a big one, and we mentioned it too, is assessing for orthostatic hypotension. I did go over to the table out there in regard to the neurogenic orthostatic hypotension. I think it's important information, and it said statistically 1 in 5. So in my opinion, 20% is kind of high. So I always think it's worthwhile to check somebody with Parkinson's to see, hey, let's do some positional changes and get some blood pressures on you. So I can report it back to the physician or talk about behavior, like different modifications, slowing down with transitions, going to the bathroom when you first get that urge versus waiting, because then when you get up, all of a sudden the blood pressure is going to drop and you end up getting a little bit dizzy and you can pass out. So I think it's valuable, especially if it's 20%, okay, to check. Ask questions, directed questions, to make sure that they're, again, being forthcoming, to say, hey, do you ever get any dizziness? When do you notice that? Tell me about it. Asking the same thing about what their last fall, why it occurred. That's important information. Saying, I was trying to get up to go to the bathroom, my feet slipped out, or I felt a little dizzy. These are all critical pieces of information to ask. Again, preventing falls, we already talked about the walkers. Walkers, canes, U-step, wheelchair is appropriate. We've talked about some of this as well, incontinence, impaired cognition, freezing, rigidity. Make sure, depending on where they're at, that their items are accessible. Because, if somebody's not in the room with them all the time, I've seen it also that they set drinks too far away, and maybe they get the desire to have a drink, so they're like, well, I'm going to get up and get it. That's a reasonable response to being thirsty. I'm going to go get up and go get my drink, or I'm going to take myself to the bathroom. So again, the benefit is having things accessible to them, or making sure, of course, that they have call buttons handy to call if they need help. And then we have to talk about responsiveness and making sure that they're reassured that we are coming when they hit the button. Assessing for speech, I think it's important. Sometimes I don't feel, I'm sure you can understand that OT kind of covers a little bit of cognition, but I wouldn't say, at least from my standpoint, that cognition is one of my strong points in helping people. So sometimes I have to bounce off the speech therapist to say, hey, what cognitive strategy is going to work best, because they're having difficulty recalling A, B, or C, or what cueing system, whether it's written, picture, verbal, what's going to best help them. So I like bouncing off the speech therapist for that. Some of the education that we can provide in regard to preventing falls, I like this one up top, and I use this quite frequently. It's called maintaining 3 points of contact. Does anybody know what that is? I don't know if there's anything legitimate behind this, but the fact of the matter is, when I went hiking in Maine, we were climbing up this mountain, and I was a little bit intimidated because I don't really climb mountains. It wasn't like this big mountain, but it did have rungs at a certain point, and I was like, wow, and I look over my shoulder, and there was nothing behind me. I'm like, this is a little bit intimidating. So I talked to the ranger before we did that, and she said, you know what, just make sure that you always maintain 3 points of contact, and I liked that, all right? What she meant was that we have 1, 2, 3, 4. Don't take 2 things off at once. It's pretty common sense, really, right? If you're holding on here, don't take a hand and a foot off, because you could lose your balance. How does that apply to people with Parkinson's? Sometimes they're using more than 2 points of contact, and when we're walking, theoretically, if you're walking without an assistive device, at times you have 1 point of contact, right, 1 foot. So when they're using a walker, we're giving them 2 more points. So when they use a walker, theoretically, at all times, they have 3 points of contact. Now, when somebody goes to pick something up with Parkinson's, sometimes they stop a little early, right? And then they start reaching for it, or they reach for it with both hands. And then they get, the reason why we do a functional reach assessment, right, is to determine how far they can reach before they get to that point of no return. So sometimes that's only like 6 inches, all right? But then I'll see them stop about 8 to 10 inches short, and they start reaching. I said, well, hey, wait a minute. Remember that test we just did a minute ago where I kind of had you stand up and you reached forward and you could only reach about 6 inches before you started to tumble? That's 8 inches. And they say, that's a good point, Brian. So how can we figure that out, or what can we do to problem solve that? Take an extra step. Keep 1 hand on the walker. I see it a lot when people drop something on the floor. They just intuitively reach down to pick it up. And I hold my breath and I say, we should try that a little bit differently. And it's the teaching, right? And it's simple. I might say, well, hold on to something stable if you want to. If you really need to reach down, hold on to something stable to reach down. Now, you might say, well, Brian, a walker is not necessarily stable, and I'll say you're right, but it's better than not having anything at all. In a perfect world, they might have a reacher and just reach down and pick it up. Or wait until somebody becomes available, but I'm a realist. I assume that they're going to pick this thing up. So I say, let's just learn to do it in a safe way. I'm getting close? Okay. Appropriate seating. Well, hold on. Back to the OT consult, as I am an OT. Make sure you get your OTs in there, right? I feel like I have a lot to offer in regard to fall prevention, and I would say a better part of my time is talking about what we can do to make sure that the room is best suited for them, what we can do to increase their safety with bed mobility, what we can do to adjust the height of the bed, what we can do to adjust the height of the toilet, appropriate place grab bars, making sure that they're using the right device for themselves, kind of coordinating with the physical therapist too. Appropriate lighting, keeping in mind that visual changes occur as we get older, right? The depth perception isn't necessarily there anymore. People have glaucoma, cataracts, a whole bunch of different things. So we ask all of these questions and make changes appropriately. So don't forget your OTs. That's what I'm saying. Okay. All right, I'm going to wrap it up pretty soon. Sorry. Almost done. That's what I was already talking about, appropriate place grab bars. That's not, you have one vertical in front, that's kind of helpful to get up and down. I like angled grab bars too, those work out pretty good. The types of wheelchairs, they have reclining, they have tilt in space for those that are a little bit further advanced. I like tilt in space because of some of the postural deficits. Even if you have a reclining wheelchair, sometimes they're still stooped forward. So I think tilt in space would be great. Tilt in space right there on your right. Those are great. Hard to get. Right, coverage, things like that, writing a lot of notes. So U-step walker. Managing rigidity, I think the best way to help with rigidity is through positioning, through activity, making sure that we don't keep people in static positions for a great period of time, helping them with their bed mobility. And then just some of the feeding stuff is the basic stuff right there in regard to some of the adaptive equipment, built-up utensils, scoop plates, plate guards, things like that. Okay. Whew. That was a little bit expeditious, and I apologize.
We are going to take a few questions, okay? Just hang tight.
Yeah.
Any questions?
Which one? You want to switch over?
This is not really a question, but with my mom, closer? Okay, is that good? I purchased a wireless bed alarm. And we're all familiar with bed alarms. I went online, I got it for $100, it was marked way down. But what was great about this, the alarm rang where I was. It didn't ring in her room, so when she rolled up a little, ling, ling, it scared her to death. So it had a 300-foot range. I could go outside and plant my flowers. When she took a nap, I placed it under her shoulders, so the minute she rolled a little bit, it went off. And then I could go and help her to the bathroom. It decreased falls, emergency visits. We could sleep at night because at night I was running in the room every 45 minutes to an hour. You have to go to the bathroom. Is it time to go? Do you need some help? We were exhausted in the morning. With this bed alarm, I could sleep. And then when she sat up, a little, it depends. You can place it at her lower back or under the shoulders. It's 36 by 10 inches in diameter, and now we have a hospital bed. Okay. So it changed our lives. Now, when I speak to other caregivers about a bed alarm, they're overwhelmed. They don't get it. But it allowed us to move in our lives, go to the corner, just relax, and it gave her comfort as well. So that's something I think we should incorporate. I do when I speak about Parkinson's, caregiving, and healthcare, because the caregiver, it is an amazing journey, but this bed alarm, it just.
Yeah, thank you. I mean, I appreciate that, and that's part of our job as clinicians is to teach families what's best suited or what's going to help, and then just really explain the importance of doing it. You know?
Can you describe a little bit more about how that U-step walker works?
Yep. So the U-step, the U-step is a little bit bulky in some regard. I mean, that's a disclaimer for caregivers that have to lug it around. It's kind of heavy, but I have somebody right now too that has PSP. It's not necessarily Parkinson's, of course, but the fact of the matter is that she uses it pretty well. It's a very it's a mobile walker with casters on it. It has a reverse braking mechanism, which I think is probably the big selling point for the U-step, is that in order for the U-step to move, you have to squeeze a brake. You don't have to squeeze both, because my person with PSP has one side that doesn't necessarily work as well. So she squeezes one brake and then she goes. It churns pretty well, but as soon as she starts to kind of freeze and have some difficulty, she lets go of the brakes, and it gives her a really strong support. So it's just it's a little bit more stable than what you would find like a rollator walker. Four-wheeled walkers can get away from you because they really do move kind of fast. So it's just, I like the reverse braking mechanism. You can use a laser attachment to kind of provide a target or a cue, external cue. And it does have metronome feature too. So that's really the overview. Quick.
All right. We'll take one, we are running late, so we'll take one more question.
With the medication window, when people start to have the off times, what kind of a time frame window is it that they have to get that medication in their system? 'Cause like I know, for example, when I worked at a group home, we had kind of like a 2-hour window. So if someone had like an 8 a.m. medication, they could technically have it anytime between like 7 and 9, for example. But I know it sounds like that's not the case with these.
Well, that's Michigan state law, is that caregivers in an assisted living facility have 1 hour window prior to a dose of medication being due or after a medication was due. So yes, theoretically, any person with Parkinson's disease has a 2-hour window, but it is my hope that all of you will recognize that 2-hour flexibility really doesn't work with most patients with Parkinson's disease that have ended up in an assisted living facility. And we really have to emphasize that needs to be tightened down. And if patients don't have cognitive problems, I very often encourage facilities to allow patients to dose their own medication at least once or twice through the day to take some of the burden off of the providers, but to make sure that medication is maintained on a timely basis. So it is Michigan state law.
Yeah.
It doesn't work for many people with Parkinson's disease, and that's where having a Parkinson's knowledgeable group that is taking care of your patient with Parkinson's disease really can pay off in dividends.
But when you write that prescription, let's say, and it says take it at, 4, 8, 12, whatever, like if it's just me living on my own, and I'm not home at 12, like, I guess how much wiggle room do I have before I might expect that I'm going to start getting some of those symptoms?
Well, it really, again, it depends on you. And some patients can find that once in a while they can go an extra 45 minutes to an hour without any problem. Other patients take their medicine with them to avoid that specifically, to avoid, being stuck without it, even if, if they're not in an assisted living facility, but trying to dose it on their own. And we emphasize taking, using a smartphone alarm, or I had one woman who went to Williams-Sonoma and got a very simple to use kitchen alarm that she would dial in her medication spacing, and then when it went off, she'd be like, oh, okay, and then she would dial it in again. It was a very easy to use alarm, and it was something that she heard, and she just had it in her purse, and she knew that's when she needed to take her medication. But that's one of the biggest issues with keeping on track, is taking medications on time, whether that's something we're doing on our own or something that we're having somebody do for us.
Okay.
Okay. Thank you, everybody. I think Dr. Wyant is up next, but we'll be around a bit longer.
All
So.
Thank you, Dr. Taylor. Thank you, Brian.